Good morning, everyone.
Yeah, good morning, guys.
Morning.
Chris, how are you, man?
Good, Matt. How are you?
Oh, man, I can't wait for this conversation, so I'm psyched. I'm pumped. So we talk about a lot of weird shit here, man. I'm not going to lie. And like, we've never had, a doctor person on here that's got your kind of background. And so I think you're going to be fun for two reasons. One, we think of care in like a let's stay healthy, not like a let's save this dude from dying in a field, right? Like that's certainly not like your go-to thought when it comes to health. But at the same time, it's certainly a component of it, right? We just don't get a chance to talk to people about that. And then we'll get into the cannabinoid stuff later today too. But yeah, welcome. And yeah, let's just get right in. Tell us a little bit about your fun backdrop.
Sure.
And then,
So
we're going to grill you with weird questions.
I am not a doctor. I don't have a
Yes,
doctorate.
okay.
Have not been to traditional institutions of higher learning. I was trained in the military as a combat medic. My background, I was I was a musician before I enlisted. Very
Of course you were.
cocky high school dropout. I could play and compose on over a dozen instruments. 15, I think, is my current count. But the passion for music and to be hungry for it wasn't there, I realized very quickly. So I decided I was going to do something different. And being a dropout, there weren't a lot of opportunities available outside of enlistment. And it turned out when I enlisted, I qualified for experimental program. At the time, it only existed for a few years. You can read about it. It's the 91 whiskey program, 91W. Second class of the first year, I think about 30% of my class finished with me.
That's not a huge number, is it?
No, that's the reason it was a temporary program. They chopped it into different programs after I think the third year, somewhere in there, and then it still wasn't producing enough viable candidates, so they just discontinued it altogether and went back to the standard medical spectrum of specialties.
Was the program too convoluted, or was it too hard, or what?
Well, yeah. So you did have to have a very high aptitude to qualify. That is a bare minimum. There weren't enough qualified candidates of that aptitude interested in medicine versus, being a nuclear physicist or getting into the special operations, things like that. There were just other corridors of interest that weren't medical centric. So finding those candidates, they tended to recruit from the medical corps. And I don't know of a single physician or PA that went into these programs actually finishing. The two PAs and the physician that were in my class, they were reclassed. I think they eventually just got out of the military because they weren't going to be reclassed outside of medicine, being so highly qualified. But it was an interesting situation to have enlisted into. So I graduated. The men were all given interesting advancement opportunities, chances to get into more training that typically requires recommendations, experience. We were fast tracked so that we could be put into places as instructors, soak up information, bring it back, teach in schools, pick up more training, go back out, rinse and repeat. And so my background is sort of checkered with these sort of training missions, in and out, working on joint operations with other countries, things like that. I've worked with Japanese troops, Peruvians, South Koreans, and it's all about sharing experience and information in those exercises. So
that's wild.
Better cohesion in the event of some kind of global emergency, etc. But that was the only time in my life where I officially practiced medicine, was inside the military, where there are no rules technically for how medicine is practiced. It's just you're either qualified for your MOS or you're not qualified. And if you're qualified, then you do everything that you can think to do, unless somebody who's more qualified than you tells you not to.
Right. So I think that's funny distinction, and I guess it really does make sense now that you're saying this. But like, if I want to put my hands inside of a body to fix it in the real world, the non-military world, I absolutely need to have gone to med school. But like in your perspective, like that's not a requirement. They don't have to send you through med school to do that. I just never thought of that either before, right? Like that's an interesting distinction, isn't it? So.
I gave an acupuncture lecture to the Walter Reed Hospital System, the DoD, and I'm like, yeah, you guys all doing acupuncture? Okay, how many are acupuncturists? 2 people.
Yeah.
65 in the class, and I'm like, oh shit, I should have trimmed this down a little bit. I'm gonna go heavy on the theory, but it's crazy where on the military base it's basically federal land, and state by state laws don't apply.
Yeah, even the federal laws don't apply.
Yeah.
And here's my question. Let's say, whatever you're done with your tours and you're out of the military, like are there people that want to transition to be a doctor in civilian life? And if so, do they have to then go to med school? That feels...
Well, certainly, yes. I mean, I got, there are opportunities for us to transition, without any college background. We were given the credits necessary to qualify, take MCATs, and try to go to the institutions of higher learning as civilians to get credentialed, licensed, etc. But I don't know of anybody personally who took that path but
right.
There are very few of us, and you get more and more fatigued every time you make your rounds looking them up, and the only thing you can find is a memorial page or something like that. So you stop looking after a while. And as far as I know, I mean, we get into healthcare administration, we get into system resource administration. I mean, I worked myself. I looked at becoming a doctor, a physician. I shadowed some physicians for a while to see what it was like, and I decided I couldn't practice medicine the way they practice it. To me, it was, it was turning the crank on the machine, coding and billing. It wasn't,
Yeah.
It wasn't doing the work. Like they were being trained and educated by the people who were paid to come and serve them that bite-sized education and upgrading on the new drugs and resources. When, these were the things I spent my nights doing. These were the things that I used to polish myself. I wasn't going to trust somebody else to spoon feed me what the best information is going to be, or what the most viable, and certainly not somebody on the payroll of the company selling it. It's
yeah.
To me,
and that's such a stark contrast to what you do in the military. Yeah. I mean, that's the exact opposite of what you do in the military, I would imagine, right? Like, there's such an acute need, like this situation is happening right now, and it needs to happen.
It's incredible in the military. I mean, we don't just have what you would call like traditional medical spectrum access, but a lot of the things that we take for granted in the civilian world, little bits of brilliant equipment, like trauma gear, like the Asherman chest seal, for example. Things like that are tested, proven, and pioneered in the military. And so in the military, we get access to stuff to use in the field long before it's approved for civilian use. So in some cases, if you're high speed enough, if you're trained and educated enough, then you can avail yourself of these options for your guys.
Sure. Yeah, and I think that's got to be kind of neat, and also a major buzzkill coming back to civilian life and be like, wait, I got to do what now?
Oh, yeah. No. Authorizations, budgetary constraints.
Yeah.
Right. Yeah, that budgetary constraint's a real bitch, isn't it? Yeah. I mean, oh, man, that's funny. Cool. So you did your stint. I mean, what got you out of the military? Were you just kind of done with it, or?
Yeah, I mean, from the age, I enlisted when I was 17 and 3/4 with my parents' permission. So I kind of finished growing up in the military, and by the time I was 19, I had regularly had battalion level responsibilities, risk assessments, things along those lines, and the things that I understood and learned had kind of taken the fire out of my belly for that particular job, or at least doing it in that context.
Right.
All the way up until about 2 years ago, I always believed that was the best job I ever had, and I would never be able to find a job that I would find as much satisfaction in as that role. But I mean, things evolve and come full circle. So I am finding that there's opportunity like that exists again. It's harder to build and to reach. But getting out of the military, I decided to work as a consultant. I would serve providers and try to enable them to practice the way I wish that I could, give them better options, give their practices better negotiating power and leverage, better integration strategies, so that they can add more value to the relationship between themselves and their patients without adding so much value to their collections and billings and receivables and all that.
Right. So that's interesting. So like, I guess when you get out of that environment, your perspective on, I guess, not just healthcare, but sort of the logic that informs like the next step in healthcare is got to be completely different from, your average perspective.
Yeah. Oh, yeah. I mean, that's what gives a consultant value, right? Is when you've got perspective and advice that you're not just going to find in the common bin.
Right, right. Yeah, which I think is cool and also maybe a little hobbling in this environment nowadays, right? Like you can't really, like you could know that, but being able to do it might be a different
and
story.
Explaining it to people, that's always, trying to get people to understand something that hasn't been strategically and carefully, diced up and made bite-sized
Right.
and easy for them to understand. It's tricky. I mean, as a population of consumers, I mean, our consumer standards are very, very high, especially for information. The ease with which it has to be consumed.
Sure.
You've got to be up there with ice cream and Doritos, palatability wise.
Yeah, right. No, that's a good point. And also, I would imagine too, Tom and I get, as I said at the top of the call, like we talk to some weird people about weird topics and it's awesome. But like the general public, even if those things could objectively help them with something that they're having, they're generally skeptical because this is not spoon fed in the manner you're talking about. So people are like, yeah, that can't be real. And you're like, well, actually.
I also like this concept of rapid iteration, right? So if it's useful, it's immediately implemented without having to, I guess, past that barrier of knowledge, right? In medical systems, even if they know something or they have a new drug or there's a new procedure, it takes so much time for like a hospital system to eventually implement it.
Well,
right. And
yeah.
maybe that's because they're not getting paid or, whatever it is. It's like, oh, we can't do that yet.
Yeah.
Like even with things like Cologuard, it's like, why are you not just using that all the time to get over that hump of,
right,
colonoscopies? Well, the insurance companies don't pay for it all, and you hit these barriers where it's like, look, no, if this is going to help, this is going to take care of somebody, this is going to fix a problem. Boom. Let's do it.
Yeah.
I'm going in for a Grail test right after this call, actually. Like I'm hanging up from here and I'm going to get a Grail test and it's an $850 test. And my wife is like, do you really need that? I'm like, well, I mean, I don't need it, but it gives me directional markers on 57 different cancers, most of which will kill you immediately, like, from glioblastoma.
Yeah, but they won't kill you immediately. They'll kill you by the time you find it.
Yeah.
Yeah, I mean, glioblastoma, like six different brain tumors are,
I'm like, long enough, that's what's going to kill you anyway. I mean, that's your expiration date.
Sure. Yeah, no, I get it. But I mean, at the same time, like if I could take an $850 test, what's more important to me, $850 or the knowledge that I could get rid of something when it's stage 1
or stage 0, yeah,
or stage 0.
Information is priceless, in my opinion. That was the thing in the military was, an MRI was something I said, oh, well, hey, let's go look and take a picture, see what's going on. In the civilian world, you got to jump through hoops, you get anti-inflammatories, and then maybe you can get a CAT scan or X-ray. And then you got to escalate to the value of the MRI before they'll actually, when all you wanted to do was just see and answer this simple question that a picture was given you.
And the escalation often costs more than the actual MRI itself.
Right. And now you're exposing the patient to risk and drugs and all these other things. And the programming behind that, it's built into the training at the medical school where they're taught to see this from a coding perspective, which isn't designed to facilitate the practice of medicine. It's designed to facilitate claims processing. That's it. It's to access funding. And all of these systems, I mean, this is where the newer opportunities to go back to where I originally practiced medicine came from was I was helping some guys out who, they pay for executive level healthcare, paying 5 figures a year in cash just to be a member of these programs.
Right.
And really in one case, it was just a glorified hospice service. They were watching this man slowly, degrade, decay. He was going to die. That was the trajectory he was on when I met him. He's back to working full time. He injured himself jumping up and down on a plyo box at the PT's office. He was in a wheelchair when I met him. But these, this thing in my head about all the king's horses and all the king's men, right? Like they spent all this money and they got the same crap in a shinier bottle. That American capitalism failed even the wealthiest upper crust, and I mean, you could, I don't know if you consider them 1%, but it's certainly up there, high up in the percentages, right? And
Sure, single digit,
and
low
They're
single digits.
they're definitely not worried about bills.
and
Yeah.
I'm a patriot at heart, right? I mean, I served, I believe in the ideals that back this country, and to me, that is the most distressing kind of failure to witness, is where in this capitalist system, it doesn't matter how much money you have, you still can't buy better. That's scary. That's really, really scary.
So I'm curious though. I don't necessarily know that is, I guess, a universal truth anymore, right? Like the world has gotten a lot smaller and technology is moving agnostic of rules. And so you've got options that may also kill you, but it also may not, right? And I think that you're rolling dice on that front, but there are certainly a lot of treatment options that we didn't have a year ago, 5 years ago, and it's every day I feel like we learn a new one, right? So, but again, that all comes down to privilege as well. That costs money.
You have to even
that's
get
not
in front of the right doctor that's aware of it, though, too. So if the information is not readily available, or if the physicians are not keeping up with, and it's like a Sisyphus kind of thing. Every time you roll that boulder up the hill, here's another pile of papers and research that they're not going to be able to stay on top of and carry a patient load and make sure that they're billing the right way so the hospital doesn't get mad at them. And once you move to that concierge model, yes, it changes, but I still think there's some things that are out of bounds where it's like, look, I read about this technique, but you can't buy it.
Right.
You can't get it. I can't give this to you.
Yeah. Well, and these are the issues where I see the opportunity, right? So there's the kind of physician that subscribes to the idea of serving you up the fish when you order the fish, right? And then there's the kind of physician that's going to teach you to go catch your own fish, to take care of it yourself. And that's where, even in the physicians who are educated in these more, population and data oriented standards, these best practices that, common sense and information can drive the changes in behavior, even if the individual training in technologies doesn't. You're still gonna bump up against this resistance, where it's the culture of medicine and teaching physicians to practice medicine is such that they believe that there is, a monetary gain to be had that should be automatic with becoming a physician. And the presumption in any trade, I mean, it's not physicians, but, pick a trade, lawyer, doctor, carpenter, right? But just because you hold a trade license, there is an inherent value there, but the real value comes from the tradesmen themselves, right? The performance, how you add value to the client and that relationship, right? And just between you and that client, nobody else. And the simple principles of capitalism, physicians are so far twisted away from those things, twisted away from the idea of relying and trusting in the value that they can serve to their clients as something that they can feed their kids and pay off their medical school bills with.
Sure.
And so they compromise, they sign contracts to be on insurance panels, and they do their compliance work with their malpractice agencies. And really a lot of this stuff, the line between what's legally required and what just makes them feel warm and fuzzy is often very, very easy to see, but they've been trained to ignore it.
Yeah, and it's funny too, because I feel like there's a lot of this misinformation or sideways information with physicians as well, who, to your point, have had this information presented to them, but they're like, well, it's not mainstream. My insurance is going to be a pain in the ass about this, so we're going to tell people, we're going to advise people against it, or we're going to steer them in a different direction because it's not an easy path to get this other thing accomplished, right? My doctor...
Sometimes it's even worse than that. Your insurance won't cover it. I'm not even presenting it to you.
Well, my insurance
not even giving you the options.
Remember, Chris, we had a guy on here, a cardiologist, real high-performing cardiologist, who we were talking about my APO1 numbers, and he said, just sort of sideways, he's like, hey, listen, it's great that your doctor did that test. It's not in a standard lipid profile, here's what I would do if you were my patient. I would go get a CT angiogram. And I said, okay, cool. I had a calcium CT score for my, last year. And I was like, all right, well, he goes, this is the better version of that. It'll test for soft plaque. Made sense to me, right? Like, I'm like, all right, I'm a healthy 48-year-old, but like, we did the first thing. It came back 0. That's generally good. But here's how you say, with a number that high, here's what you should be looking at. Now, I didn't know that information, right? So he came, but he's like a ninja cardiologist. This guy's like super tech forward, like whatever. So I go back to my concierge doc, who again operates outside of the boundaries of like kind of what we'll call normal medical like boundaries. And he said, yeah, he's right. That is, your insurance isn't going to cover it though. So I'm just letting you know. And I was like, well, let's put it through and see. Fast forward a couple of weeks, I get a rejection letter with a 800 number. I call them up. I get this lovely woman on the phone who basically was like, yeah, you don't have a medical condition to do this. I said, so let me ask you something. What you're saying is that there's no practical value. And I did this to kind of bait her. I was doing this on purpose, but I was like, so what you're telling me is there's no practical value for any healthy person who's not in coronary, acute coronary failure, essentially, basically, like some major problem. There's no value of any kind to have this test done. And she laughed, caught herself, paused, said, let me consider my response, and then said, that's not what I'm saying. But she's like laughing because she understood the absolute lunacy of the rejection. Fast forward, it did not get done. I didn't end up doing the test. I kind of found some other research that kind of tied it tighter to that other test score. And for now, that's okay. But here's the thing. That also was an $850 test. For $850, there exists a tool today that's not in dispute of any kind, that if I had the results of that and it showed a buildup of soft plaque in my heart, I absolutely could stave off where that leads to if I know today, not tomorrow, not next week, not next year. And for $850, I think even in a practical nuts and bolts standpoint, an insurance company would save hundreds of thousands, if not millions of dollars per person, knowing that information ahead of time. And that's the part where I'm like, yeah, let's lean on the fucked up nature of capitalism all we want, but this pretty much should be defined by capitalism as sane, and it's not.
Yeah, it doesn't make a lot of sense.
Yeah, no, the Grail test, the same thing, right? Like it's like, okay, you can tell
everybody and then
just put this in the fucking water, man.
Chemo,
test everybody. Why not?
One thing I can say about our Western healthcare system is that what you just described, I would associate with a very typical private payer phenomenon with the insurance companies, because they're not motivated by anything other than profit, which is collect premiums and deny payments, right? And that's how you get more profit. If you are a Medicare recipient, that standard doesn't hold true. And there are many, many, many programs that are data-driven based on their approval. I mean, smoking cessation, right? So smoking cessation is something that a physician could build a practice around. It makes more money than standard consultation work does. And there are more people who could probably benefit on a day-to-day basis seeing a doctor about that, right? It's funded, and the doctor could make like $800 a patient from Medicare and Medicaid patients, and it'd be covered if that's what he's doing on a monthly basis, and 2 attempts per year. I think 8 consultations, these very, very deeply funded consultations per visit, and it's or per treatment cycle, and that's just because Medicare can see, as a social support mechanism, they've got to look at the numbers based on taxpayer dollars, that down the road, if all these people keep smoking, we're going to be paying for hypertension, we're going to be paying for cardiac disease, we're going to be paying for this and that, cancers and all of this. So instead, they're going to front load that money and try to get ahead of that huge bomb of cash they see going off down the road, statistically speaking. But that's, Medicare is the gold standard in third-party payers. You ask any provider, they'll tell you the exact same thing. That if they're in PPO land, where everybody pays cash or has a very high-end practice, third party, they'll stick to that if they can. But if they're anywhere where there's mixed payers, Medicare is the gold standard, because Medicare doesn't play games with their practice. That's because it's not a game to Medicare. That's it. The physician can go to jail for cheating Medicare.
Right. Yeah, no, I think I just don't see this getting easier actually, because as the technology blossoms more, the rate of legislative change or even statistical awareness at the insurance level, I think, is showing up to be a lot slower than the rate of technological advancement. And I think that this sort of discrepancy between, hey, I've got these tools that could save my life, change my life, etc., are increasingly less available to people who want to use them, because it's like, well, if it takes a decade to approve something, I mean, there's 58 versions of that tool that'll come and go in that amount of time. So like, you're never going to catch up, right? Like, I mean, it's
well, and the FDA's sort of system of approving exclusivities and monopolies stifles innovation and alternatives in the traditional mainstream space. I mean, traditional funding and investment then can't find its way into new projects because these other projects have a hold for 15 more years, 20 more years, et cetera.
Yeah, I worked with a guy years ago who, and this was in like the early 2000s, he wore a USB stick around his neck, and his whole idea was like his company took your genome and matched it up with companies who had disease treatments that didn't meet the minimum FDA threshold. And I can't remember what the numbers are now, but it was like, can't kill 50% and has to help at least this, whatever those numbers are.
Yep.
And he said, he goes, there's so many people we meet that have like a lung cancer cure, but it only works on 5% of the population with this disease. That's it. He goes, it'll never get funded. It'll never get clearance from the FDA. Like, they're just never going to look at it. But if you were one of those 5%, wouldn't you want to know about this thing? Like, and I'm like, fuck yeah, I would. Absolutely. Like, who wouldn't? And this was like 20 years ago. So I lost touch with him. I'd be curious to see if anything ever came out of that. But like, conceptually, I think it's like where we are at technologically now. There's no reason in the world why I couldn't be in a matchmaking AI driven service that says, hey man, I've got this wacky disease that 5% of the planet's got, or 1% of the planet, or whatever has. I want somebody to tell me when this shit is available to help me move the needle on this, right? But again, that's the same thing. What we're talking about, though, that's never going to get FDA approval. It's never going to be funded by anything. It's never going to, I'm never going to be able to go to my Walgreens pharmacy and pick up a prescription for that, because it's all completely done. I don't want to say under the table, but certainly in a new paradigm that we don't have a definition for.
Yeah, it's almost like that Lorenzo's oil type situation where it's like, there's not enough people that need the drug. There's no money in it. We're not going to make it. And that's, I mean, Chris, I'm so happy you're on, because normally it's me railing against capitalism.
I meant to say something, but I'm like,
it's only when capitalism's corrupted that you got to rail against it.
Well, I would say what system isn't, where is it not? But definitely when it comes to dealing with health and medicine, this is when we see these giant disparities, right? Even how many people have, God, in Baltimore, we've had people like, well, they're released from the hospital, they're stable. We know there's something wrong with them, but they have no insurance, right? They're stable enough to leave. And that happens all across the country, but they're not better.
Right.
You just got them out so you can get somebody that can pay on the bed. Yeah.
Well, or somebody who's funded to be on the bed because they ran out of money on that Medicare recipients tab.
Yeah.
So walk me through what the bridge looks like between all this stuff that you kind of up to now, and then like when you get over to sort of your, cannabinoid concoctions thing, which is a very different way of talking about, personal treatment, right? Like what did that bridge look like? How do we get from post-military consultant guy to magic potion guy,
So it's a long story. I got married and had a bunch of kids in the process, but the main features of it were my self-managed PTSD, the boredom. I have a real crippling problem with boredom, and so
you're in good company here.
I was relatively successful as a consultant, and I don't know if you know anything about this, but when you are successful, it gets really tedious and boring very, very
Yeah,
quickly.
for sure.
So you got to find other things. So COVID came. I was running healthcare businesses. My consulting business spanned DC, Baltimore region. If you were getting private practice, outpatient diagnostics done by neurologists, there's like an 80% chance it was my techs and my equipment in that region doing the work.
Ah, got it.
We were doing
Okay. All right.
doing quite well at the time. And then I had 2 of my own clinics I'd opened in West Virginia just to get closer to my clients and understand better what their issues were and the practices I was managing. And the whole thing culminated with me realizing that I was so bored I didn't want to do any of it anymore. And COVID came, and there's lots of free money for businesses like mine. I could have metastasized my business model with the kind of money they were throwing around during COVID. It would have been fun for a little while, but it just, I didn't want to keep perpetuating something I knew I wasn't into anymore, and I wasn't passionate about it. I had these long rides from the middle of West Virginia back to the Eastern Panhandle where I live, and there was a commercial on a podcast I was listening to, or maybe it was a news story, I can't remember, but it was something about a Canadian subsidiary of a major beverage interest rolling back for another quarter their THC-based beverage in Canada because of clarity in the bottle issues. And the light bulb that went off in my head was that's a really dumb problem for such a big company to have. And so I decided that
I love it. Yeah.
I would get some THC distillate and figure out how to get it to go into water nice and clear, and then I throw my hat in the ring, see if anybody's interested. I overshot my goal in the process of figuring it out, and developed a very elegant pharmaceutical grade liquid freight delivery system that I can load with THC or any other API, from cannabinoids to alkaloids, amino acids, synthetics, and it doesn't matter, and turn them into an aqueous format that is so passively bioavailable because of the particle size we achieve with the API, that you could consider it an alternative to injection, just on contact with soft tissue.
Wow. And that's like on subcutaneous, sublingual, all of the above.
Wherever you put it, that's where it becomes.
Wherever you put it. Yeah. Wow.
So you get interesting, effect profiles, that are different pharmacological consequence profiles. So CBD or CBG is a good example, right? You get cannabinoid receptors outside of the brain, so you can put this stuff on your hand, on your foot, your knee, etc. And long before it's traveled back to the central nervous system, it's going to have diffused to the point that you won't notice a central effect from any of these things. THC topically would work very similarly, right? But if I work with something like metragenine, alkaloids from kratom, then that dose sublingually has the same effect profile and latency as the same dose on the back of the hand, because the mu-opioid receptor affinity outside of the brain is very, very low. There's no receptors to diffuse it between there and the brain. So these particles, with the kratom solution, you get a 6 nanometer average particle size in the particle population. And so there's no membranes to stop it from, just passively falling through until it sticks to blood particle and starts circulating, or until it finds receptors for which it has an affinity for attachment.
That's awesome. And I had forgotten actually that we had talked about the kratom, the metragenine stuff. Like that is that actually, I'd love to hear a little bit more about that too, because that's actually
most interesting for me.
Yeah. And I forgot all about this, Tom. I actually meant to kind of front load you a little bit on this, but let's dive into that a little bit, because I think that there is a lot of sort of hyper practicality in kratom right now.
It's such a cool, weird opioid that doesn't hit that part of the brain that seems to spike addiction.
Yes, if it's used correctly, right?
Yeah.
So what's interesting, and I've only been studying. Well, I've been interested in hemp and cannabis since I was a teenager. So I mean, my experience is much broader with cannabinoids than with kratom. I've been into kratom maybe for about a year. It's my favorite go-to pre-workout supplement. I absolutely love the kind of pick-me-up it gives you. That's the traditional use of kratom. If you look into
so are we talking the green or the red? Like I always get confused.
So that's a bit of a misnomer, right? So
okay.
So these different color, they call them strains. It's really just preparations. It comes down to the way the leaf is cured and prepared.
Okay.
That tends to limit the expression of certain alkaloids and bring forward the expression of other alkaloids. And so that changes the profile. And that's where you get those profile changes. Now, when I work with kratom, I'm focused specifically on the dosing of the primary active alkaloid, metragenine. Which is the one that has the most research done on it. So it's got the best understanding of safety profile, et cetera. But it's the one that kills pain. If you use the metragenine in small doses, it's very uplifting, very stimulating, kills pain. It appears to maybe provide some improvements in neuroplasticity. But I know I get a way better pump in my workouts when I use just a little bit of kratom before my workouts, and it lasts well after the workout, well after I've cooled down. It's still working like 3 shots of espresso that lasts for 6 hours. But with no risk of the jitters, you don't have any of the downside of caffeine, and you don't
tachycardia and things.
Yeah, and it doesn't just like drop off abruptly and leave you like hanging or something. You don't notice when it stops working. You're just like, oh, well, that was nice, but I'm back to normal now, and that's nice too. The issue with kratom is how it's consumed. Right now, most people who take kratom, they're taking powdered capsules. They're drinking beverages that are made from crude emulsions, things like that, and they're consuming 50, 100 milligrams a serving. And this is where the issue, the risk of kratom comes from. The traditional use of kratom is very much a microdosing thing. In Thailand,
even chewing the leaves,
a couple of leaves, they chew them, hold them under the tongue, and it helped the farmers get through a longer day farming more productively, and recover better from that day. And so, these extracts and concentrates that are used to create an opioid-like effect, that effect profile comes from, and when I say opioid-like effect, I'm talking about the sedative, the respiratory depression, the heightened states of euphoria, all of that type of stuff. That comes from when you consume these high milligram amounts, 50, 100, 200s of milligrams, that goes to the liver. The metabolites that come out of the liver, there's 2 primaries. There's the 7-hydroxy, which has the same binding affinities as let me turn my do not disturb on. That was dumb. Which has the same binding affinities as morphine. Very similar binding affinity. The 7-hydroxy has another issue, though, in that it has a poorly understood mechanism of metabolism, secondary mechanism in the human blood plasma, where it spontaneously converts into indole dioxyl metragenine, which is several times as potent as morphine. So that's like seeding your bloodstream with a bunch of little opioid time bombs. And that's when you hear stories about people who took some kratom and then they fell asleep and then they didn't wake up again. That's where those types of stories come from. Now, the other side of kratom toxicity is the oh crap! I'm not going to remember the name of the secondary metabolite from the liver, but there is a metabolite that is not a primary like 7-hydroxy, but another minor constituent that comes out of the liver that is just pure poison. When it's tested in rats, it stops their hearts. When you see people take kratom and they get these symptoms, talk about shakes, sweating, hypersalivation. That's what's happening. They are showing.
So is this a genetic predisposition for that? Or is this just a dosing thing? Like I took too much, so the metabolites.
Both, right? So the issue with metragenine, anyway, at least amongst all of the other alkaloids, is that the rate of metabolism varies person to person by a factor of 20.
Wow.
So you can try to predict, but what's safe for one person is dangerous to another person. But what's also safe at one time of day for one person might be dangerous at a different time of day, or maybe with different gut contents. So when you're trying,
and that's just a general metabolism requirement, right? Like my metabolism.
Yeah, but we hear about that with heroin overdose too, right? I mean, the same thing, right? The guy took the same dose, but he was in a different setting, and that OD'd him.
Well, the difference there with heroin is that heroin is unregulated. So what he probably ended up with was something that was
something adulterated.
Because when you're going direct to bloodstream, you are getting your effect profiles, even with something illicit.
You're missing first pass.
It should be the same profile each time. So if you got a different profile with the same dose, it's because something else was in there if it was intravenously delivered.
Yeah.
Now that's where
Right.
technology with kratom, really shines, right? If mitragynine is put into your body using my technology, even if you drink it, it's absorbed on contact in the lining of the mouth, the esophagus, the stomach lining. I've not had any clients that I've had tested report that they get any of the effects that are associated with it being processed by the liver. And that's effect profile stays consistent, whether it's sublingual, whether it's topically applied, whether we put it into one of these cool little spray nebulizers. But all of that stuff makes
Is that oral or nasal?
That's oral.
Okay.
Yeah.
That easy. Cool.
Yeah, but but it makes it so that when it comes into contact, and with the the inhaled one, that's like a topical bronchial application essentially, but direct to the bloodstream, and then instead of thinking about it in terms of getting an active into the bloodstream that's going to circulate to a very specific target and hit it like a hammer, these sort of organic and botanical compounds, they have more broadly spread affinities, which is what gives them sort of a gentler magic, right, than typical pharmaceuticals. And so you end up making, well, like I said before, medicine where you put it. CBG, for example, topically, great anti-inflammatory. Centrally, it is fantastic for pain and inflammation that is caused by central nervous system responses. But if you put it into one of those nebulizers and inhale it, the proximity of the vagus nerve to those bronchioles there gives you a sort of tweak in homeostasis that is a little off-putting if you're not, anticipating that this is an effect that could happen from it. And also, in my opinion, made it so that the CBG wasn't a candidate for that route of administration for consumer products. But, it's a sort of, for me, it's really cool to know and understand.
Now I want to try that.
Yeah, now I'm like, shit, how do I try that? That sounds fun.
How do we do that?
Yeah. Because I was just like, well, what does that mean? How do I know that? Yeah.
And make sure you bring a designated driver. We can open the fridge up and let you get into some stuff.
Yeah, that's funny.
Look, don't invite us twice, man. We'll be
there. So quick question for you though, like when if I put the mitragynine on my skin, let's say, or if I inhale it, is the idea that those secondary things that come out of the liver just don't get triggered because by the time it gets to your liver, if it gets there at all, it's just so diluted that it doesn't.
It appears that the binding affinities for mitragynine when you introduce it to the bloodstream are so high that not a lot of it makes it around to the second pass. And
I see.
What we've seen is that you've got to load theoretically hundreds of doses, and the dose of mine is about 2 to 5 milligrams. It's much lower.
That was going to be another question: is like, what is microdosing on this? Is it single digit milligrams? Is it
when you're going right into the bloodstream, you don't waste as much, so you get a 1/50th to 1/100th of the typical dosing requirement.
I see.
With that, you end up with much less risk of compromise
toxicity,
circulation of the compounds.
Sure. Now I got a question for you. You're obviously a bright guy with a very high aptitude for this stuff. So you might be a little bit of a unicorn in this case, but certainly you're not the only, bright guy on the planet. How come nobody else is kind of doing this kind of delivery? It would seem as though any of the deleterious potential here is ameliorated or eliminated by your path. I just kind of curious, like what is blocking that kind of adoption?
Well, it depends, right, on the context. So in the general, hemp and cannabis space, you have a lot of noise. Like my all of my solutions get digital light scattering tests to validate the nanoscale of the particle sizes in the solution, the distribution of the particle sizes, all of that, because it's of consequence to the profile of the product. But I can't use the word nano in describing my product because of the amount of noise created with that word, like Han Solo, parsec. Nobody uses it the right way, and I got to start giving lessons on centimeter, millimeter, micrometer, and then it's not worth it at that point. Now you've used too many words and made too many attempts, so you're wasting money, right?
Sure. No, that's fair. Yeah.
So we try to streamline it and just focus on the outcomes, the technical upsides, the ease of use. It can be weighed and measured like water. It can survive pasteurization without changing properties, all of that stuff. The only thing I haven't been able to do with this liquid is freeze it and have it return to the same chemical state, same crystal clear chemical state. It still retains the same pharmacological profile, but it doesn't stay as attractive if it's frozen. But
is it? Do you get precipitate? What's happening?
Well, I think what it is it's the crystallization of the water is destabilizing the micelle packages. That's causing them to sort of cross-link, and that creates a larger particle, which results in clouding in the water.
Okay, I see. And I was going to actually ask a few blurbs ago, but is that large? You said it's material. The particle size is material to the outcome. Is that a really fine and tight window of opportunity there, or do you have some forgiveness there in particles?
Generally speaking, anything that you can get and keep consistently below 50 nanometers or so with most substances is going to stay clear in water. Also on that scale, anything is going to also be passively absorbable. How bioavailable it is, you need PK, PD studies to prove, down to the nitty-gritty of exactly which one's working better under which circumstances, because there will be variability. But generally speaking, we just aim for maximum bioavailability. I aim for the most refined particle size I can get, smallest possible. The smallest membrane in your body is in your small intestines, 200 nanometers. Generally, everything smaller than that can be passively absorbed.
So, let me, maybe I missed this earlier, but is the clarity of the liquid sort of a visual yardstick for bioavailability, so that the clearer you have it, is
Absolutely.
that how that's,
yes.
Yeah, okay, I got you.
Yep.
Right, okay, well, that makes more sense. Okay, I got it. So basically, and I guess there's a palatability situation too. Nobody wants to drink cloudy drink, right?
Yeah.
Like if you're talking about a commercial component, right?
Now when you're talking about anything that is bitter and you're, because now physics becomes a big part of the way these things perform. Cannabinoids are a good example. They're very bitter compounds. So when you put those into these sorts of environments, these aqueous solutions, you create a lensing effect because you increase or multiply the surface area exponentially. Contact.
Oh, interesting.
So unless you're masking the flavor somehow, then
right, it's tastes like shit.
And now it helps that you only need a couple of drops of this solution per serving, so you can hide an awful lot of it, in a 12-ounce can or something like that. But it's but if you just put the solution itself straight on your tongue, it tastes like the most bitter of poisons.
Yeah, and it's funny. I don't know if there's some kind of sadism in me or whatnot, but it feels like if it doesn't taste like shit, it's not healthy for me or something. So it's almost like if it tastes, the worse it tastes, the better I think it's working. I know it's ridiculous.
Just paraphrased a Chinese medicine idiom. The worse it tastes, the better it is for you.
Yeah. Well, it's funny.
Bitter. Americans do not do bitter.
No, they don't.
No, and it's funny that Ben Greenfield in his book Boundless years ago had this whole thing on carrots, and he's like, carrots naturally are a digestif, right? You're supposed to eat them to aid in the digestion process, but they're super bitter. So we basically genetically modified these things to taste like, popsicles, and that's how we have our carrots now. So we went and found, I went and found a farmer who's growing sort of the more natural, and dude, they tasted horrible. I was like, this tastes terrible. This is a carrot? Fuck those things. I never would have eaten this thing. But but it's funny because it's absolutely true, right? This is almost medicine, but it tasted so bad that they're like, yeah, we can't serve this to people. We can't. So you got a delivery mechanism. That's cool. Did you sort of, is there a sort of an infinite end result of that discovery and process that you have? And are you now trying to sort of figure out what else you can package with it? Because it feels like that's really universal in
that's sort
application.
Of what the business that brought us together originally is about. Biochemical phytotech is just the development and refinement of plant-based medicines using that delivery system and model.
Right.
And we've discovered since then also that we can apply it to synthetics and even animal cellular products.
Oh, interesting. So that gets interesting, I guess, delivering anything to, I don't know, drugs or treatments to
I'm
animals.
thinking insulin.
Yeah, or insulin, actually. Yeah,
Insulin,
that's another.
peptide synthesis is
Oh,
something
now you're
that we can
speaking Tom's
facilitate
language.
in our
Wow.
laboratory. My lab partner is a small molecule synthesis guy. He was he was on the faculty of the university, but he's been a PhD chemist for about as long as I've been alive. And I would put my team there at the university against any team at any university or NASA or anybody in the material sciences. We're faster, we're better. We'll get to the answers quicker.
Oh, interesting. And so, like, I guess, do we sort of have to broaden our lens here and say, like, what can't we put in it? Like, is that, or are there certain things that this is sort of like definitely better for?
I mean,
It comes down to molecule size, or
so it gets down. The smallest particles I've created in this system are 5 nanometers. So 5 nanometers is obviously incredibly small.
Yeah, it's very, very deep.
I'm not sure. I'm not sure if we can, with the process I'm using, get them any smaller. The merits of this process are that only 2 human beings alive know how to reproduce it. It's a tedious, artisanal, low energy process that I don't think that relies on thermodynamic tricks I discovered by accident. So I'm not sure that it's something anybody would put funding into trying to compete with directly, because everybody else likes easily scalable digital motorized equipment and things like that. So it's not as simple as just throwing ingredients in a pot and mixing them up. There's a sort of art to dialing in the particle size, making sure the population of particles is consistent and not,
Right.
all over the place. I try to aim for no deviation up or down from the average of 2 nanometers. So if it's a 5 nanometer particle,
so it's pretty tight. You're keeping it real tight. Yeah.
We want a
is there
clean spike
what's
on
the
that
practical?
test.
What's the practical benefit of dialing it from 50 to 5? Like, it seems like, is the juice worth the squeeze at that, or is 50 enough and we can kind of keep it at that?
Arguably, 50 is plenty. Between 30 and 50 is where most companies that can produce a reliable nano emulsion, even pharmaceutical companies, that they tend to be in that range. I would argue that, if you take a liquid that contains an emulsion, right? So if you can smear it across the skin and keep it all there, that between 5 and 50, there might not be a lot of difference in how much of it ultimately gets into the body. But if that liquid were not a gel or something, say it were aqueous and it were going to pour over the hand, I would say that the opportunity for it to be absorbed is better with my solution than with
the 5s rather than the 50s.
And there's a bioavailability consequence to acknowledge there.
That is interesting, but it's like one of those things, like if I have to tap one of 2 humans out of 8 billion to get something done, it's been my experience that, hey, what's the second place? Is that going to be like good enough? Right? Like, it's like, it's cool, but I do a lot of cool stuff in technology that it is tantamount to academic masturbation and nothing more. Like, it's like, okay, well, this is kind of neat, but I'm not really sure.
What are you going to do with it?
Yeah, what am I going to do with it? It's cool that we pulled it off and we can all pat ourselves on the back and we can kind of, say, oh, this would be great if. But the if is like, okay, great. I just took my pool of clients from 100 that would use this to 0.4 of a client that might use this.
Sounds
it's
like
okay,
at the lab.
Yeah, right. Well, no, exactly. Right. And like some of it you have to go through as a stepping stone for another thing. Right. But certainly, some of that is just like, wow, I guess I am that good. Now what's next? Right. Like, kind of like, I don't know, so the just out of curiosity then, out of all the stuff we're talking about, that Merlin's potion, that I think it's CBGA or CBG0. I can't remember. THCA.
Yep.
I got to be honest with you. I've owned a cannabis accessory company for 24 years. I've been in this space for a really long time. This shit is fucking amazing. Like, I don't know what you got in there, but like, or what's going on. I would love to talk chemically. What is actually making that feel like that for me? Like, is this just one of these nanoparticle things that you've got going on?
No, you can't do that to stuff that you smoke. Yeah, my pharmaceutical grade products cannot be heated. Like most pharmaceuticals, you don't want to treat them chemically in a way they're not made to be treated. So you don't.
Okay.
So like this thing here, there's no heat involved in that. That's just a vibrating mesh disc.
Okay, got it. That's it. Okay.
Yep.
And so that's going to be a better delivery mechanism for any of the metragine and any of that kind of stuff.
Well, and it's unrestricted, like where vapes are restricted because they're heated. They have emissions that are consequential to people around them. This is the same as an asthma delivery system.
Okay, gotcha.
So it can be used on the bus, the plane, the school, wherever. And it's not something that can be restricted by smoking or vaping policy because it isn't.
Right, because it isn't. Well, could we take this THCA and put it into one of those things, or is that compound not?
So that's one of those things that's okay. Well, we're going to go on a little side here. So
no, that's fine. Yeah.
So THC is very, very an interesting molecule. It is a weak partial agonist of CB1 receptors. Now, anybody who smokes it would not tell you that that they associate a weak effect with it. Especially if they smoke it in very pure forms. If you use my delivery system and you load it with THC or THCA, THC delta 9 is very, very mild. You can take 5 milligrams, you could take 500 milligrams of it, and it has the exact same effect because it's only a weak partial agonist unless it has been changed in some way. And so there's two primary ways that we tend to change it when we ingest it. We either hydrolyze it in our livers into 11-hydroxy, which is ultra potent. 100 milligrams in tends to be 1 milligram out of 11-hydroxy, and that's enough to blow most people's minds.
Absolutely.
Now then,
I was just gonna say, that sums it up. Okay, okay.
11-hydroxy in the lab, and that's something that can be put into that. Now the other side of that.
Oh wow!
So that just cuts it to the chase. You're like, you save the processing, you save the conversion.
That is an edible but instantaneous.
Yes. Yeah. And so a drop of you're talking about a liquid that's 15 milligrams per milliliter. So you're talking about 1/15 of a milliliter being what you would want to be analogous to a 100 milligram consumable experience. And small enough that amount that you wouldn't be able to detect that it was in whatever recipe, so you wouldn't have to mask it or hide it. It's just such a small amount.
No, God, no.
But then reliable and consistent, regardless of the gut contents. Once you know what buying the ticket for that ride gets you, it's the same ride every single time.
Right. Which is really what the guys at the Hopkins lab said about the psilocybin experiments that they run over there. They're like,
the other side of that, though, and this is the very, very tricky part of THC, right, is thermal degradation of THC. If you smoke it, what you get high from when you're smoking it, and I've done the test in the lab to prove this, does not test as THC. It creates THC metabolites. It can make you fail a drug test for THC, but it no longer tests chemically as THC. And with what we know about, THC analogs, homologs, and all of these synthetics, we know that just because it doesn't test going in doesn't mean it won't test coming back out, right? So I created a machine in the lab. We call it the pyrolyzer, and for any nerds out there, get on me for calling it that. It sounded way more sexy than the combustor, so so we went with pyrolyzer. But it's a system for the controlled thermal degradation and recapture of cannabinoids. And so we use that to sort of redistill, pre-treat, pre-smoke THC, and then put it into the delivery system to create the direct-to-bloodstream analogous effect of smoking, but without having to actually smoke. And so that's the other side of so you have edible and you have smoked effect as applied or translated through my technology.
So when you say thermal degradation, though, I mean, that's I was just going to say, can that go to decarbing as well as lighting it on fire?
The very first part of it, right? So THCA to THC, right? That's a standard decarb. It happens at about 220 degrees, where the water bond breaks off the acid component of the molecule, and then it becomes a real fun delta 9. But again, the delta 9 direct into your bloodstream isn't going to be anything to write home about. It's not particularly special. It has to be thermally degraded farther from delta 9 to actually be what people associate with the high that you get from smoking a joint or hitting a bong. And the rate of that thermal degradation is what changes the effect profile from a joint to a blunt to a bowl to a bong.
Oh, interesting. Yeah. So I'm pretty much non-combustion guy for a long time. And so I've always been curious. I've read tons of articles on this, but like it's hard to test. Is like, if I put the vaporizer at 375 versus 420, technically I should be getting different terpene expressions that as they go up. And we've all seen those charts that like, at this this temperature, this goes and this goes and this goes, right? I'm not sure I've had like enough rigor in my experiments to actually know the difference between those. But I'm curious, are we basically talking about a similar thing like with your machine is like kind of
Sort of, yeah. So with the well, when we do this, we reintroduce the volatiles after the degradation process. So we're only degrading cannabinoids. We work with isolates and distillates, and then we reintroduce to that recaptured oil whatever volatile profile we want it to have.
And that would be your terpenes and other things.
Phenolic ester compounds, ester alcohols, things like that. But then, and that's the stuff that you asked before. What makes it feel interesting? What gives it that taste, the profile, all of that. That is all of that volatile aromatic spectrum, and terpenes are just one slice of it. And that's what makes it so much more interesting than what you would typically get, I guess, at a smoke shop or dispensary.
It's literally nowhere near any of those things that I've ever had at a dispensary. And I'm friends with nerds as well that process on their own, and I've never seen anything like this before either. Which is actually one of the things that I find so compelling about this product is it's like. The only way I can describe it, and these are crude words, is like it's the cleanest thing I've ever put into my lungs, like in terms of like THC, anything, right? Like it's just crystal, it's like squeaky clean, right? And it's just feels completely smooth in every measurable way that I could crudely describe this.
Well, and there's tricks to mitigating the downside of the experience of smoking, right? Like, so, refining extraction processes and using refined products, making sure that you're as advanced as possible allows you to mitigate the exposure to things like floral waxes in your combustion process. There's a terpene called delta-3 carine that, as far as we can tell, it just makes your eyes red and your throat kind of harsh, but it doesn't really benefit you in any way.
No other ride.
It's an unwanted guest at the party.
Yeah, it's got an aromatic profile that isn't really special or anything, so nobody really seems to notice the absence of it. And again, everybody seems to notice the lack of harshness. So
right.
There's understanding the constituents that you're dealing with and how they're dealt with. Like I've never met an institutional scientist studying the combustion of cannabinoids who smoked a joint. I mean,
which is funny,
right?
Isn't it?
It's a big world. I work with my lab partner Aristotle on the pyrolyzer, and then we're building it. And he is a genius in chemistry, so brilliant that it overlaps into other stuff like engineering. And so, he'll pull the glass down on the hood because we're talking about building some glass piece for capturing the smoke from this electronic nail that I brought into his lab, And he's like, well, I'm not an engineer. And then he proceeds to engineer this beautiful device on the hood for me. And that's how we have to get it done, is we've got to literally invent these things, design them from spec for the purpose, test it. It doesn't work. We build it again. And being at the university helps because the university's glass blower is at our disposal for these types of things. And so if we can draw it, they can make it, and then we get
They can make it. That's amazing.
That's
what a cool trick to have up your sleeve.
Yeah.
The amenities at the university are fantastic. We got a molecular characterization lab, so where most places they got to pay a lot of money to know exactly and definitively what's coming out of their processes. We get, we can do nuclear magnetic resonance imaging and verify the molecular structure with image if we have to. I mean, then we can take it very, very far, and not just we can do liquid chromatography in-house inside of the lab, and then there's gas chromatography, different flavors and versions of that at the molecular characterization lab as well. But
and each one of those machines is cost prohibitive for the average person to have.
Oh yeah,
you can't keep up.
UNBC is sort of, and the University of Maryland system is sort of a golden child. They get all of their equipment through an alumni relationship with Lockheed Martin. Their lab, their technical center, their technology. I would prefer to be there than at their flagship facility in College Park.
Wow. Oh, that's
So
very interesting.
you know what's kind of funny? He kind of brought it back around to military, like just a little bit right there. He's like,
Yeah,
here's a
all
company
roads.
that's tied to military.
Yeah,
Well,
that's funny.
that's where the money gets spent. It's just
Yeah,
No, of
yeah.
course, of course.
So I've got like an extremely direct question here.
Mhm.
Where do we get this stuff? Is it available for consumers? Is it
so
just
I've got right now a website, merlinsmagicpotions.com. I think that Matt's familiar with it, but you can buy the
Yeah,
content.
totally. We're trying to sell it on Head Shop right now, actually.
Yep.
That's pretty awesome.
Yeah.
The biotech products, I've got these bench proofs of concept. I'm producing and bottling samples like a Keebler Elf all the time for prospective brand and manufacturing clients. But so far, none of these have been scaled by anybody. So, these are technologies that are on the table. I mean, and I tell everybody, I tease everybody with this. Some of the things that I've invented are things that only exist because somebody put the idea in my head that it doesn't exist and should. And then, with my free time in the lab, I made sure it existed. So,
Sure.
I can make anything. It doesn't matter, what the target is. If it's a reasonable target or if price isn't an issue, then we can hit the targets.
Yeah, and I think I love that idea. And what I find really cool about this is like just in our circle of influence, which is hardly global in span, just Tom and I, right? We have like 5 guys that I could think of that would probably be able to use this kind of thing. They just don't know you exist and you don't know they exist. And if that's just in my circle of influence, imagine how many other people out there are in the same exact position. And I think this kind of harkens back to what we were talking about a little while ago about the rate of technological expansion here. We're just in this kind of unprecedented, here's this random dude from Maryland who's got access to $1 bazillion worth of crazy high-end shit in his lab, and he's just fucking around. And meanwhile, there's another guy who's like, God, wouldn't it be nice if I had all this crazy shit I can do all,
I just want to sign up for clinical trials, man.
Yeah,
I don't care how it gets done. Sign me up.
The other thing that gets me all the time is the astronomical amounts of money I see spent on R&D that is subpar, doesn't go anywhere, wastes a ton of time and money. And I'm just like, guys, if you'd given me a tiny, tiny piece, I'd have taken it so much farther.
Yeah, just give me a couple bucks. Yeah. Yeah. No, and like that's exactly right. And I think that's the other thing that gets lost in the static these days is like just because you know a bunch of big words and you kind of have a vague familiarity doesn't actually mean you're good at this. And there's a lot of people that are like meh at a lot of things, and like that's enough. If you got a rich friend or access to a lab, meh will get you there. It'll get you to the starting line, right? Like, and then I'm from the Bay Area, man, and like I laugh as a lifelong technologist who's from the Bay Area. I said, funny thing about the Bay Area is you don't actually have to be good at coding. In fact, you could be fucking awful at coding. As long as you have a bunch of rich friends and you're just chasing the next IPO, you could actually go an entire career and not produce anything that means anything to anyone. Yeah. And retire loaded. Like that's like an absolute, that's happened countless times. And I feel like that's the same thing in this like little weird playground that we all play in, right? It's like there's a lot of people that are just bad at their job. Like I don't know what else to say.
Well, and it's like they get into it and they don't know why. They don't have the passion for it. Or with the institutional types, you've got 2 types. Like Aristotle, who I work with, is a genius. He has focused on the things he's passionate about his entire career, which means that when other things are popular and getting funding, he's still in his corner doing the thing that he's into and not getting funding. And as a result, he is way better and more competent than any other scientist that I could ask to work with. But he also doesn't have all the rich friends and the connections.
Right.
Well-financed, his retirement isn't vested yet, all that kind of stuff, right? So that's just the way that it has to go. But, ultimately, that's where the magic happens, right? Is the people who will do it in their own kitchen. And I mean, this delivery system I described to you, I invented it in my kitchen. With spoons and beakers, and I burn my nose on the hot plate because I'm trying to see into the glass. And that's
crazy.
Yeah. But that's how you make the advancements and get to the next levels. And everybody else who's collecting the money and turning the gears and they're holding the places, but they're not the cutting edge. They're not going to get anything. They're waiting for, the guys like us to show them where the next level is, and then somebody will pay them to start pioneering it too.
Yeah, totally. Yeah, we talked about this like probably a year or two ago with these sort of desktop gene sequencers you can buy now, right? They're like the size of a candy bar and they USB in your computer and you know.
Yeah.
And I'm like sitting there going, some guy, what was that guy? He put like a thing in his chest that let you feel north like a bird.
It's so weird, right? You hear
like
the biohackers and they're like, "Oh, I take this supplement," and I'm like, "This dude like is implanting tech. Like, you're not playing the same game, man."
Well, and it's funny because his rationale was like, "Well, birds could do it." I'm like, "Well, that's really not a good reason."
That's wow.
Like, that doesn't feel like a valid excuse to do this, but okay. But yeah, like those are people that are doing some crazy shit and they're doing it in their basement on like ad hoc equipment.
Well,
and like,
sounds really, really crazy. But to me, I've got different things I work on in my notebooks and stuff. I've had friends call me like a Da Vinci kind of guy, but I've got designs for self-charging batteries I'd like to pioneer one day. And one of the things I designed was an ornithopter. Yeah, and that was actually a Da Vinci-esque inspiration. But a prosthesis that turns a person into a bird so you can fly. But that's where I would see, the passive ability to tell north as being pretty valuable is
well, sure, in that case, yeah, I mean, why not? But I see now, I laugh at that because I say, well, if I did have this thing, it probably comes with a Bluetooth GPS unit. I don't need something installed in my fucking body to do. Like it's got a control panel. There's an iPhone app for that. Like it's a whole thing. Like I don't need to like worry about installing something in my chest. I'll outsource that to my iPhone app. Like that's totally fine. Yeah, that's funny. So, what's your sort of like, I guess, current trajectory? Like, how do we bring this back to like present and future? And what does that look like for you? Are we on the hunt for product people or what?
Yeah.
Where are you at?
Well, yeah, right now, I mean, we're on the hunt for manufacturing partners and for license holders for anybody interested in picking up the ball with any of these loose technologies. The cannabis and hemp technologies in particular, I think, are set up to and cleanly sidestep any rumbling disruptions from regulations and things like that.
Sure.
I mean, these things will be years ahead of any issues along those lines, but also add an incredible amount of value. On the other side of that, I was avoiding it for a while until I realized that maybe it is something I'm meant to be doing, but I am looking for additional high-end clients with advanced neurological problems. I have one. I will have a full panel of 10 this year total, no more than that, who are interested in having their problems turned around. And they...
Are we talking about dementia, Alzheimer's? Like, what are we talking?
Dementia, Alzheimer's, any neurodegeneration, severe head trauma, things along those lines. Doesn't matter how old the head injury is. Doesn't matter how progressed the case is. I've got a decent success rate with some testimonials for interested parties from sufferers of Alzheimer's, Parkinson's, severe TBI, that we can talk about what it looks like to be some of the first to turn the corner on these things and see what it looks like to, well, come back to a new kind of normal, not necessarily normal. But, this is something that between the technologies and my past in healthcare, I feel like is an opportunity to kind of close the circle and get back to trying to design a way of taking care of people without compromising the way I used to.
That's pretty cool.
And that's a very hotbed of activity now because I feel like we're in that space where we've got the quantitative models with AI to track like a lot of data points in a lot of different directions, which we've never really had up until fairly recently, right? We've got a lot of people that are getting old enough to have this be a problem way more frequently than anyone would like. It's sort of like the magic convergence of problems and solutions that are making this very attractive problem to solve, it looks like in the news.
Yeah.
I feel like there's new information monthly on this now.
And everything everybody's got going to try to help is not very good. It's not helping. Alzheimer's is a great example. Dementia, they prescribe statins for treating ameliorating plaques, right? And it turns out that was all bunk, right? $70 billion drug industry that was absolutely just selling side effects that did not change the state of disease in any way whatsoever.
Wow.
And the author of the study that was used to validate it had to pull the study and say, look, they doctored my images here. This isn't the information that was supposed to be presented. And so this is invalid. And,
Wow.
and so all of these people who are having these terrible, life-changing disease states happen to them are also being prescribed and farmed for their money with drugs that just make it worse and don't make it better. And
Wow.
for now, the issue right now I see it is a chronic cycle of designing from the bottom up, built on compromise, built on standards that are meant to farm a population for money. And so that was why I mentioned that it's going to be 10 clients. They have to be clients who are high net worth individuals because they're going to be helping me construct this from the top down instead. We're going to design and build their interventions without compromise. In some cases, in some of these test cases I've done, I've invented interventions along the way while I'm handling the case because they needed something that I didn't already have. So that type of program intervention is what I'm offering, but only to an extremely limited number of people. So I can build out the system. And then I'm in the process of training coaches. I have some retired special forces operators, colleagues who in the future, if this all, bears fruit and starts to develop, they will start to step into my shoes and carry the load going forward.
Is it a easily transferable skill set to do that? Is it?
Well, it's not a skill set per se, as much as it's a mindset, right? It's about it's about discipline and being humble, not being distracted by your own identity and ego and having, I guess the part that I have to teach the most is the curiosity aspect, is how to stay open-minded and interested. But a retired special forces soldier makes the best kind of raw material for building these things on top of. And then they command respect passively as well. So it's, win-win.
Yeah, that sort of mindset feels very naturally neuroplastic. Like they could kind of they're just processing outcome potential, not necessarily like ego or preconceived notions. They're like, oh, you just tell me how we get to the right spot.
But then the full spectrum of human emotion and interaction is still in that toolbox of theirs.
Yeah, sure. Yeah. But like, as opposed to say a PhD candidate who might have like ego-led motivation, right?
Well, and
like
an awful lot of indoctrination in the way that he's taught to approach the problem as well.
Yeah, correct.
That's an interesting anecdote about military safety. There was a safety study that I was a part of collecting data for. Infantry, Rangers, and Special Forces were evaluated for rate of injury on jumps, parachute jumps. And the rate of injury in special operators was higher than the rate of injury in Rangers, which was higher than the rate of injury in infantry, the infantry having the lowest rate of injury per jump. And this was the opposite of what the command structure expected. They expected that when they pour more money into training, you get better outcomes in performance. But the problem was with these guys' advanced state of training, they were more prone to improvisation and believing that their way of doing it was right.
Sure.
And so the issue with digging a groove that's too deep or too specialized is then you stop being curious about what's outside of the trench you've dug yourself into, right?
Right.
Because everything you're looking for is down in that trench.
Yeah.
That's super fascinating, actually. And
it makes absolute sense, too.
I got like 50 examples from the regular non-military world, right? Like the professionals that I know every day that do the exact same fucking thing as that. Like, I mean, almost letter of the law. Like, it's crazy. That's really funny. So like with this dementia thing and the advanced cognitive stuff, like is that, I mean, it seems like there's a bunch of things you've talked about today that could really inform that, from like the particle size and how you can deliver things in a way maybe that's not like what everybody else is doing. Is this sort of like all baked into sort of how that is working?
Yeah, well, and there's a component here of advanced neuroanatomy and an understanding of basic clinical practices and how to structure treatment programs and paradigms. But in the case of somebody, for example, stiff person syndrome, that's not something I've dealt with, but generally speaking, the problems that a person is dealing with when they're having that disease manifest from a lack of available GABA in their neurological system. So it keeps them from being able to activate, to move and control movement. So if I was dealing with that kind of client, I would use my delivery system to supplement directly to the nervous system the missing GABA and figure out at what intervals and what levels GABA.
Oh, I see. Yeah, that makes sense.
Directly address the chemical imbalances. So the difference between me and a normal doctor in doing this is I don't need a drug company to pick my active ingredients for me. I do that based on the appropriateness for the client, the
Right.
profile, what they may already have. But then I don't need that API loaded into a delivery system for me either. I choose the appropriate route of administration. I decide the delivery system, and then I put it together for the client.
It's like that. Well, this reminds me of that story of that woman, the scientist who studied MS and then got MS, and she was like in a wheelchair. Terry Walls. That's right. Yeah. And it turns out the cure was a very manicured and calculated amount of food in very specific ways. So it was like, you needed like 3 onions for dinner and all this other stuff. It was like a crazy, she has this like wheelbarrow filled with vegetables, and it's like, it seems odd from the outside, but she's like, no, I've done the math. Like, this is right. This is the right answer. And to your point, it's like sort of like a top down, just, fix. She's like, well, I know this has to happen, so I'm just going to do that, and it's going to fix it. And then she goes from a wheelchair to walking around giving TED Talks, right? Like, and like, oh, look, no dollars in drugs. That's interesting.
Yeah.
Like,
and that's what it takes sometimes. I mean, I figured out a lot of the issues that I've had in my life come from the fact that I didn't eat based on my blood type. I have an O positive blood type. I only need to eat red meat to live. That's all I need.
It's so funny that you should say that, because I'm just about to go down this rabbit hole, and I actually am going to a blood test, like I told you, right after this, where one of the things is I have to have them remind me of what the fuck my blood type is, because I cannot remember to save my life.
Don't feel bad. I wore it on my neck for 4 years, so
yeah, right. I was just, it's on your dog tag. Yeah, right. So
I'm going to be tapping you though first.
Because I think I'm coming around to this again. I think there's a lot of sage wisdom in that. Like, it makes sense that, like, if I'm built a certain way, that there's certain things that just should function better. Like, it's not an all or nothing proposition, but it's certainly like if we're following statistics, this is statistically likely.
Yeah.
Right?
Well, and it's 100% true. I mean, I noticed, like, I have family history of bad joint problems, arthritis, things like that. And, I could feel it creeping up in my late 20s, aches, pains, getting up after a long drive and thinking, oh, is this permanent now? This low back thing happening? And the answer was no, it wasn't. But it took a couple of years of obsessing and trying to figure it out. And ultimately, I had to get so extreme. And it was, a book, I forget the name of the doctor who I was reading about, but there's a guy who was saying that just to eliminate the variables and get back to baseline and normal, he just went bare minimum, kosher salt and red meat once a day. And that was so that he had a baseline to start from. And that worked for him. It was extreme, maybe not for everybody, but it turns out that extreme works very well for me. My skin looks great. My bones feel great. I can hit the floor playing around with my kids and bounce right back off of it again. It's a big tangible difference doing it the right way.
That's awesome. And that's kind of why I was going back down this rabbit hole. I'm like, there's a couple things. I'm getting a little older. Some things went away. I started using the Beamer mat every day. So that PMF thing has actually made a huge difference in a lot of things. And I'm like, okay, so I did that. How do we kind of like layer on the next layer? And I think the food part is like next on my list to kind of start to pull back. But it's funny. I just talked about this last night with a colleague, and I'm like, yeah, I got to get on this. I'm going to a blood test. I just got to like move this to the front of the pack.
Not all red meat's created equal though. Everybody should have a relationship with a farmer, a couple of farmers, ideally. Yeah. I put in labor locally and make sure that I can get, things I need, good prices, and I've got the right relationships. But the beef I get a side of beef I got a freezer dedicated to that purpose, is holding that
Yeah,
side
me
of
too.
beef. And it's, from a farmer who I know, their family only raises a couple of dozen head a year because they don't need more than that for their family. They only use drugs or interventions on the cows if they get sick, and they give you all of the vet paperwork on any cow on the kill dates. It's, they're good people. And that's,
Sure.
if you're going to put stuff in your body, you should make sure you know where it's coming from. I can't eat beef from the grocery store anymore. It doesn't work.
Yeah.
My kids even say that our ground beef is the best burgers they've ever had because it's all grass-fed, grass-finished from Hereford County, which is like a half hour from my house. And I'm like, same thing. It's a little bit of a pain in the ass buying 700 pounds of beef at a time, because you're buying an entire cow. But if you can get over that, which we have, it is actually like, just eons, it leaps and bounds better than steak in the grocery store. I agree. It almost tastes like synthetic to me.
Like it's not. Yeah. It's not as good. Not worth it.
It's definitely different, right? I mean, it is. And my kids said that there's no way they were going to taste the difference until we went out to like Red Robin and had a burger. They're like, this isn't really.
It's not a good burger.
No, this doesn't taste right. Yeah. So, well, Chris, man, listen, I could talk to you all day. I love it that you spent time with us. Thank you so much.
My pleasure.
Where would you like to send people? Is it Merlin's Magic? Tell us where can we send people if they want to learn more about you?
Try those wonderful tasting concentrates. Go to merlinsmagicpotions.com. We are launching a line of new disposable dab pens with those concentrates loaded in them.
Awesome!
Engineering went into that, so it'll be a very high quality experience. That's coming in the next 2 weeks, I believe. And anybody interested in the biotech licensees, manufacturing partners, etc. It's biofillc.com. And then there's contact forms there, etc.
Perfect.
My email's chris@biofillc.com for anybody that just wants to nerd out.
Yeah, cool. That's awesome.
Sweet,
we will make sure we point to all that. And Tom, I've got some stuff here, samples wise. That
I definitely want to try some stuff.
Yeah, no, it's fantastic. Yeah,
notes and feedback are appreciated, guys.
Yeah, no, I absolutely, I told you, I've actually said to a bunch of people that I absolutely love your products. I do not have, and I'd love to know if you ever make this available, but I'd love to get my hands on some of that metragenine vaporizer and try that out.
That one I'm really interested in too. Yeah,
that feels like something I definitely would like to try. Just because, like, the pre-workout thing is interesting. I think Tom and I both perked up. We're like, really? I
gotta go swing a kettlebell and and a couple, and it's.
Well, let's schedule a day for you guys to come down to the lab, and I'll give you guys some samples.
Where are you at?
UMBC. Do you know where the Technology Center on South Rolling Road is?
I'm not far from there. I know that. Yeah, I'm up in Towson and Tom's in Parkville, so like
it's really not that bad.
Yeah. So we're not too far, but yeah, I mean, nerd out on a lab tour or something. That'd be fun too, because we're
that'd be super cool.
Very high nerd factor over here. So,
absolutely, look forward to it.
Yeah, cool, man. All right, thanks again, Chris. Have a great weekend, everybody.
Have a good one, guys.
Take care.
Take care.
Be subversive, irreverent.
Health is wealth, but you knew that.
Everybody knows that.
But so is following us on social media at Irreverent Health. And check out our website for more exclusive content at irreverenthealth.com.
Oh, I like this.
Thanks for tuning into this episode of Irreverent Health.